Hi, everyone. Welcome. See everyone starting to trickle in. Good afternoon. We're going to get started in just another minute. We'll wait for everyone to settle in. Hi, everyone. Good afternoon again. I see everyone chatting through the box. We have people joining us from all over the country, so all the way from the West Coast. Thank you. We're glad to have you. We're just going to get started in another minute. We're waiting for a few more people to come in. I love seeing the chat box so full. Good to see everybody and where you're joining us from. I saw a lot from New York, New Jersey. Great to have you. All right, well, we'll go ahead and get started. It is 12:02. So welcome again. We're grateful to have you join us today. If you're not familiar, my name is Amanda Bassos, and I am the Regional Resource Director for Caron Treatment Centers based in South Florida. And today's webinar is entitled Advances in the Treatment of Alcohol Use Disorder, Trauma, and the Brain. As a reminder, we will be conducting today's session in a webinar format. So that means all of your microphones are muted, your videos are turned off. While you can see and hear us, we can't see or hear you. So despite that, we still want you to participate with us. So please use the Q&A box, the chat feature, ask any questions, share any comments or thoughts. We love to interact with all of you. And depending on the volume of questions that we have, if we can't get to your questions at the end of our time together today, we will have someone from our team follow up directly with you over the next few days to answer your questions. So don't let time be a barrier for asking. Today's presentation is eligible for 1.5 continuing education credits. So speaking of, we would like to thank our educational partner at CE Learning Systems for helping us provide these credits through co-sponsorship with the American Psychological Association and the American Society of Addiction Medicine. Now, as a reminder, you have to be on the call for the duration of the webinar in order to be eligible for your credits. And in order to receive your credits, you will need to complete the evaluation at the end of the webinar. A link will be emailed directly to you from ce-go.com. That should happen as soon as we end this session at 1:30 on the dot. If for some reason that doesn't happen, feel free to reach out to myself or any member from the Caron team. We'll be happy to help you. But as soon as you finish that post-evaluation, you'll have immediate access to your certificate of completion. So now that housekeeping is done, I am very proud to introduce our two presenters today, Dr. Barbara Krantz and Allison Steiner. So starting with Dr. Krantz, she is our Director of Addiction Medicine here at Caron Renaissance and Caron Ocean Drive in Florida. And she has worked in the recovery field for over 30 years, so bringing us quite a bit of wisdom today. Dr. Krantz is an expert on the national and local prescription pain medication epidemic and the medical science behind the disease of addiction. She lectures on numerous topics, including the biochemistry of the brain as it relates to addiction, and she's an advocate for neuroimaging to effectively diagnose and treat addiction. Dr. Krantz has led a study with Scripps, Florida, and the University of Miami to identify effective and innovative treatment therapies and relapse triggers. In 2007, the Medical Review Officers Certification Council certified Dr. Krantz as a medical review officer to evaluate workplace drug and alcohol test results. The Palm Beach County Medical Society honored Dr. Krantz in 2008 with its Heroes in Medicine Award for her leadership, philanthropy, and commitment to the field of medicine. And in 2010, the American Society of Addiction Medicine inducted Dr. Krantz into its Distinguished Fellow Program for her substantial and lasting contributions to the field of addiction medicine. Quite a lot. Thank you, Dr. Krantz. Next, we have Allison Steiner. She has served as the neurofeedback specialist at Caron here in Florida for the last 8 years. Allison is board certified in neurofeedback through the Biofeedback Certification International Alliance. She's responsible for creating and implementing neurofeedback-based treatment protocols, which results in about 62 to 70% of participating patients reporting clinically significant changes in depression, anxiety, or stress. She works one-on-one with clients and with the clinical and medical departments to create a neurofeedback treatment plan that's appropriate for all clients' needs. And as one of the first employees in the neurofeedback program here at Caron, Florida, Allison helped to build the Alpha Sim program and set up the neurofeedback laboratory. She's actually developed research presentations and shared them at neuroscience conferences as well, including the Advanced Loretta Neurofeedback workshops in 2015 and 2016. So once again, on behalf of all of us attending today, Dr. Krantz, Allison, we're so excited to learn from you today. I'm so grateful for your time to create this presentation, and I'm going to turn it over to you all.
Thank you, Amanda, very much. And we have no disclosures. You just saw that slide. Excuse me. So good afternoon. Today we really want, we're going to give you an overview with as many specifics as we can regarding the areas of the brain and their involvement in alcohol use disorder, as well as concomitant physical and emotional trauma. We all know as clinicians that we're seeing a whole lot more family of origin issues or more aware of, I should say, family of origin issues and emotional trauma, as well as we're seeing more TBIs than I've ever seen. You're also going to be able to have a basic understanding of neuroimaging, as well as QEEG, brain mapping evaluation tools. And we're going to give you an introduction to the neurofeedback. And at the end, we want to make this practical for everybody. So we're going to do case studies. We're going to do 2 case studies that incorporate everything that we've been talking about and the modalities that we use to get the success that we have. Can we bring this over? No. Yeah. Sorry, I just had a problem with the slide. So, because the slide's cut off here. Perfect. Thank you. So, this is not evidence-based treatment by any means, but what I thought was interesting is even in the Middle Ages and the Renaissance period, they believed that there was a problem with psychosis and schizophrenia and other mental health issues that it had to do with the brain. So this is an illustration showing a colonial surgeon actually attempting a trepanation procedure, about 60 minutes of constant drilling. I'm sure that was fun. And they thought that they could release the demonic possession and that would cure the patient. It was not successful, to say the least. And my slide is stuck. Okay, now this could be fun. This is moving on into the 19th century. This is a full-size hollow wheel that they actually used, thinking again they're thinking the issue is with the brain, and I respect that, that they could spin the patient into loss of consciousness to essentially rearrange the contents of the brain. I think we've all heard of some of the other techniques, the insulin shock and the frontal lobotomies. Frontal lobotomies really didn't work either, and there were significant personality changes secondary to that. So the bottom line, we're going to talk about the brain today, and the human brain is about a 3-pound mass of gray and white matter, and it really is involved in everything that you do. Your brain is really who you are. So besides the basic bodily functions, the autonomic functions that that we just take for granted, you know, I'm breathing and my heart is beating, the brain interprets and responds to everything you experience. So we know from research, even in utero, as the brain is developing, that those memories are being laid down. The brain shapes our thoughts and therefore our emotions, our perceptions, and our behavior. So it's extremely important that we speak about this and help the patients understand what's going on and how they can actually change their brains. And that's what's exciting about being in this century. Again, I'm an old doc. I've been in practice over 30 years, and I've seen all the changes from, you know, not understanding neurogenesis, not understanding neuroplasticity, and just thinking, you know, when brain cells are dead, they're dead. But the capacity of the brain is awesome. So we're actually born with 200 trillion nerve cells. We lose 100 trillion by 2. One nerve cell can grow 70,000 branches. And then if you take 100 trillion times 70,000, we essentially have an infinite capacity for learning and storing information. So you don't have to worry. I will share with you, I am in recovery. And when I was in treatment, I'm thinking, oh, when I get to such and such an age, like now, I hope that I have my brain function, because I destroyed brain cells, and we used to think all of that, but that's not true. So as we continue to learn, we're actually growing branches on the nerve cell. And again, it would take 3 million years to fill one human brain. This is diffusion technology. So technology in itself has come a long ways, especially, and that has helped us understand better the brain, especially with functional MRIs and perfusion studies. This is diffusion. This is showing the nerve cell connections. And there's at least 80 to 100 billion neurons. I'm going to go briefly through the geography of the brain. I think most of the people on this call have a basic understanding, so I don't want to spend a lot of time on that, but I do want to hit some of the highlights. So again, the lobes of the brain, frontal, parietal, temporal, occipital, the limbic system, the emotional seat of the brain. So thalamus, memory, amygdala, hippocampus, anterior cingulate gyrus. We're going to briefly talk about all of these. Prefrontal cortex is the CEO of the brain. It's the executive function of the brain. So it's forward thinking, critical thinking, impulse control, medial prefrontal, body regulation, emotional regulation, that flexibility, empathy, intuition, or personality, and being able to moderate social behavior. Medial prefrontal, again, impulse control, but it's also activated by observation of social interaction and during mentalization or meditation or prayer, and retrieval of remote long-term memory. Anterior cingulate, definitely conflict monitoring. It's vital to the cognitive functions, especially reward anticipation. I think there was a study probably several years ago, but it was cocaine recovering, early in recovery cocaine addict, and a patient without any substance use disorder. And they were showing them videos and nature videos and then cocaine paraphernalia. And on the PET scan, you could see very clearly how the anterior cingulate actually lit up when they showed the paraphernalia to the the early recovery cocaine addict. So that reward anticipation is very real. Responsible for rendering new memories permanent. Corpus callosum. So I chuckle at this slide because when we talk about the brain, it's about the size of two fists together. So when I'm lecturing and there's a mixed audience and the males in the audience, they're like, yeah, we've got a bigger brain. Well, ladies, we have more connections in the brain. So between the right and left hemisphere, we certainly make up for the size of our brains. Temporal lobe function. Temporal lobe is mood and memory, language usage, listening, reading, social cues, rhythm. Very important in the evaluations that we're doing, and we'll go into detail on that. Parietal lobe is sensory processing and direction sense, spatial processing, localizing objects in space, distinguish left and right, creating reading maps. It really is the where pathway. Occipital lobe, sight, color, perception, lines, depth. Cerebellum. So the cerebellum, besides being the motor control and the posture and the gait, it also has a lot to do with executive functioning. And we know today that the speed of cognition and integration is coming from the cerebellum to the prefrontal cortex. Allie's going to speak about that with the neurofeedback, and we'll show you in case studies also. Limbic system. So there's different areas of the limbic system. Hypothalamus, we could talk about the 5 F's, the flight, fluid, food, and I'll say flirt for sex, but it is that survival function. The hippocampus is essential, again, in the formation of new memories, so short-term and long-term memories. Basal ganglion essentially is important in the positive forms of motivation, like eating, socializing. It actually has to do with our formation of habits and how we acquire and process knowledge. Amygdala is the alert center, the initial warning system. It interprets the emotional significance of the experience and emotional behavior and our motivation of being involved with it. Memory tagging. So the main parts of the brain involving memory are as on the slide. So right now you're listening to me speak and you're looking at the slide. So you're receiving electromagnetic information directly from the senses, our vision and our hearing, into the thalamus. And then that goes into our prefrontal cortex. And then the hippocampus will evaluate the context. And then again, the thalamic connections to the amygdala are faster and may cause us to react without thinking. And we understand that. You know, AA talks about people, places, and things being cues. We've all seen this with patients. The brain is electrochemical. When neuron cells fire, they exchange chemicals and then produce electromagnetic fields. So I think what's important about this is that every thought that you meditate on, there's a physical reaction in your body in the form of an electrical current traveling along the nerves of our brain. And with that is the production of various hormones and neurochemicals that flow through our entire body. And they're going to be chemicals that help increase homeostasis, or perhaps chemicals that actually cause chemical chaos. When we talk about our thinking and our ability to change our thinking and therefore change neurohormone response, that's very real. So again, Marcus Aurelius, way back when, had a quote, "Our life is what our thoughts make it." And that's very true, because the quality of our life and health is really brought about by the quality of our thinking. Our life is an expression of our thoughts. And we talk to patients about this. We have modalities in place to help them reframe different thoughts, different experiences, different memories, whether it's cognitive behavioral therapy or dialectical behavioral therapy or EMDR. But this is all based on what we know scientifically. So what is memory? Again, information that's coming in through the five senses. The brain stores that information. Proteins are made and used to grow new branches to hold the information from our thoughts. So the more, and this is logical, the more you meditate on a thought, so you have a patient that is ruminating maybe a lot of negativity, the more you're reinforcing that thought, you're reinforcing the chemical release of that thought, and the more branches on the particular neuron and the stronger the memory. So this is memory, because this is a neuron. This is axons, if I can point to it. Axons and the dendrites. It's like spaghetti. And this is an electromicrograph of a thought. So this area down here, I mean, what do you think, what kind of thought do you think this would be? It would be a very strong thought, something that the patient is ruminating about. Mally's picking up on QEEG, high beta waves. More information now to help our patients understand that our thinking is extremely important in our recovery process. It sounds like a simple statement, but I know when I was in treatment, where the science was in the field was kind of like the Nike commercial, you know, just do it, 90 meetings in 90 days. And AA is important, I'm not saying that, but it didn't help explain the primary symptom of this disease, the compulsivity, that irrational, irresponsible returning to the drug despite adverse consequences. So now we have so much more information that we're able to relate to our patients, and there's so much that the patient themselves can do. We can give them a lot of hope because we're able to help them understand that they can actually change the real estate in the brain. They can change their thoughts. They can change how it's laid down in the brain. They can change the neurochemical release that's associated with those thoughts. So saying all that, there's no single factor that determines whether a person will become a substance use disorder. Biology and genes, we know, is probably 40 to 60%, but environment plays a big part in it too. So that environment, whether it's a chaotic home or abuse, parents' use and attitudes, community attitudes, early use of the drug, availability, the route of administration. We know that the more addictive drugs hit the brain the fastest through the blood-brain barrier, and of course, the effect of the drug itself. So let's talk about epigenetics. This really is a rapidly growing area of science that helps the individual actually can turn off certain genes and turn on other genes. So epigenetics essentially means above the gene. Bruce Lipton, I believe it was Bruce Lipton, that was a scientist at Stanford way back in the 90s. And when they were looking at stem cells, and we thought we would solve everything with genetics. And he used heart stem cells and was putting them in solution and then checking them later. And I think this is true, was legitimate, that they changed the solution, and the heart stem cells did not become heart cells, but muscles. So we know that genes are not our destiny, that environmental influences, including the solution, but including nutrition, stress, emotions, adverse childhood events, can actually modify our genes without changing the basic blueprint. And that's really nature and nurture. We also know that we have probably 100,000 cellular proteins, and you can actually create 2 more variations of those proteins from the same same gene blueprint. And my computer is stuck. Okay, good. So Folletti, I bet a lot of you are familiar with Folletti studies, but this really was a landmark study. And we understand today that adverse childhood events really cause a public health issue in our society. So he had 17,000 Kaiser Permanente members surveyed, and they looked at adverse childhood events. So whether it be divorce or whether it be domestic violence in the house or drug use or sexual or physical abuse. But he actually found in that study that 2 out of 3 reported at least 1 adverse childhood event. 1 out of 5 reported 3 or more adverse childhood events. And more important is that it was actually strongly predictive of negative outcomes later in life. So they talked about diabetes, heart disease, a significant increase in those diseases that have to do with adverse childhood events. And that makes sense to us in the field because, cortisol levels go up with stress. We get decreased immune activity with stress. And again, the memory of the adverse childhood event is laid down in the brain. And again, with neurochemical release that is not, it doesn't cause homeostasis. So each adverse childhood event associated with a 2 to 4-fold increase in substance use disorder. These are just the circles that they have looked at. Again, abuse, emotional, physical, sexual abuse. Every patient we see, we ask those questions. Emotional and physical neglect. I mean, you could be an extremely wealthy person and be raised by nannies and, have significant emotional neglect. Household dysfunction, mother treated violently, household mental illness, incarcerated household members, parental separation, divorce, and of course, substance abuse. So again, back in the day when John Milton wrote Paradise Lost, he obviously knew what we were dealing with today. The mind is its own place and in itself can make a heaven of hell and a hell of heaven. And my computer's stopping again. Confucius, to be wronged is nothing unless you continue to remember it. And again, we see this in treatment all the time. Patients that aren't able to walk through the pain and suffering that they've had and hold on to that in that anger and the severe depression that we see. And my computer's stopping. Let me see if I can change the slide. And I am the last person as far as IT literacy, so kind of interesting. So today's science really is hovering on a precipice as we recognize the responsibility and the impact of our thinking and the resulting choices we make, which have consequences right down to the ways in which the genes of our body are expressed. So we're talking about epigenetics, we're talking about neuroplasticity and the ability to change, which is awesome because thoughts change structure in the brain because they're changing memories. Brain itself changes itself in response to experience. So even with trauma work, EMDR, if we're able to change the narrative of that trauma, we're able to help the patient. And this is all based in science. So there's changes in receptors and neurotransmitters. Again, our thoughts, our non-conscious thoughts are 95% of how we are through the day. So it's part of our intellect, our will, our emotions, our memories, our habits, our deepest feelings that cause beliefs. And that drives the conscious mind. So when we're awake, our reactions even depend on what's planted in the non-conscious, our perceptions and our behaviors. And that is essentially what we do and what we say, and those experiences then are laid down in the mind again. So it's a cycle. So if we say our perceptions are based on what is coming in from the non-conscious mind, obviously our past can sabotage us unless we actually deal with the thought and associated emotion. And that's what we try to do in treatment. Usually what we ruminate about is what we think about. And again, you see a stronger thought in the micrographs. While we're building memory, we're also experiencing emotion. So the chemicals in our brain carry the info from our thoughts and also carry the emotion that you experience with those thoughts. And sometimes even that fact itself, when you're talking to a patient and you're able to relay that to them, then it starts making sense. And they're like, there is hope. I can change my thought. I can prune this thought. And then the associated neurohormone, and I'll feel better. I love this thing, this abstract. It was in the British Medical Journal. So this 29-year-old young man had been in construction since he was 19. And he was up on a ladder and he jumped off the ladder, and you can see that 15-centimeter nail went right through his steel toe boot. And he started screaming in pain. Now, this was not the first incident, obviously, that he had with a nail through his boot. And he'd been to the emergency room before. So they couldn't even, I read the whole article, when the docs were trying to move the nail, they couldn't. He was in too much pain. So they actually medicated him with fentanyl and midazolam, which are two great medications to use to calm somebody and take pain away. What's interesting is when his boot was removed, he was miraculously cured because the nail had actually gone in between two toes. There was no abrasion. The foot was entirely uninjured. But I think this is a great example of, again, our memory, the associated neurochemical with it, and maybe an exaggeration, but this was a legitimate experience for this gentleman. Brings us to neuroplasticity. So thank God for neuroplasticity. We can change. The brain's ability can change. We know it's strongest during childhood, and it certainly impacts our ability to learn and change behaviors. So again, a lot of hope with this disease in treating our patients. We can be the synapses that can be strengthened, weakened, or eliminated, and new synapses can be formed. So new memory can be formed in response to experience. We're going to go through the genetic and neurocognitive evaluations and therapies briefly with what we use with patients. But again, at the end, we're going to do 2 case studies that will show many of the modalities that we use. I just wanted to talk about the neuropsychological testing. We do R-bands and a MCMI for the patients. So looking at personality structure and as well as cognitive proficiency. We have a lot of patients, especially at Ocean Drive, that have a lot of intellectual reserve. So we need to do testing that we're going to pick up any kind of deficit. The pharmacogenomics testing has been invaluable, I think probably to a lot of psychiatrists, but it's really the study of how an individual's genetic variations affect their response to drugs. That's the bottom line. So they could be a normal metabolizer or a slow metabolizer, where they're going to get normal is fine, slow metabolizer, and they may get every side effect in the book of that medication. So that's good information to have. So we'll usually genomind a patient. We'll do a pharmacogenomic, especially someone that has significant mental health, whether it's anxiety, depression, bipolar. But you can use it for medical too, even with knowing if a patient's going to get the myopathy from statins. QEEG and brain map and neurofeedback. You're going to learn everything you ever needed to know by Ali today. SPEC and FDG PET. What we have found is that those are perfusion studies. So there are structural studies with like a CAT scan or a regular MRI, but perfusion studies, especially in patients that have had multiple traumatic brain injuries, it's important, especially again, if we see on the neuropsychological testing that there's a cognitive decline, that we will look at that because we can help perfusion deficits. And if you think of even just sitting on your hand for a long time, and then the function of the hand doesn't work quite as well. So we're talking about the same thing with the brain. Hyperbaric oxygen, we have used in some of the case studies that, well, both of the case studies actually that you're going to see today. And that's just 100% oxygen under pressure that not only increases oxygenation in the blood, but also increases oxygenation in the tissues. So with that, I'm going to turn it over to Ali. I need to pause the computer. I believe I can do this. And Ali will give you everything that you need and need to know about neurofeedback.
Hi, everybody. I'm so excited to be with you all today. And we're going to spend a little bit of time talking about integrative neurofeedback therapy, including EEG and QEEG. So integrative neurofeedback therapy, as we define it, has 4 distinct aspects that we'll spend some time going over this afternoon. The first part of the neurofeedback process is the baseline evaluation, which includes a review of clinical history, which we're using to determine the appropriateness of the patient for QEEG evaluation and neurofeedback therapy. During a clinical history, we're mainly looking for diagnoses that are, or experiences that are amenable to change through neurofeedback, such as trauma, anxiety, inattention, concussion history, things of that sort. We're also looking for medications that may complicate the evaluation process, such as atypical antipsychotics or narcotics, as these medications can have a profound effect on the QEEG output. And we want to be aware of that as we are analyzing the brain. We don't want to attribute medication to a patient's naturally occurring brain pattern. So the QEEG scan is the part of the process that really determines the rest of the treatment from a neurofeedback perspective. It is our initial assessment and consistent marker of change throughout the neurofeedback process. We utilize the QEEG scan to determine appropriateness of treatment for neurofeedback therapy and to create a protocol, which is an individualized treatment plan for the brain. This protocol is based on symptomology, relevant neuroscience, and areas in the brain, in the patient's brain, that are registering as statistically significant in the QEEG. As I don't think I clarified, QEEG stands for quantitative electroencephalograph. And it is a standard EEG backed by a normative database that I'll talk about a little bit more in the presentation later on, and dive into the normative database a little bit more. So going back to the protocol is used to train the brain during the neurofeedback sessions. We recommend a minimum of 10 neurofeedback sessions during a patient's stay with us. Research suggests that the more sessions you do, the better, but that entire process is data-driven and is based on changes seen in the brain. I would say that the majority of our patients complete 10 sessions, and we will try to get them to 20 during if time allows. This entire process is bookended by assessments of both objective and subjective self-assessment data. We're constantly analyzing the EEG and also providing surveys and subjective measures to help quantify the patient's experience. So some of the clinical benefits of neurofeedback include anxiety, inattention. The diagnoses that benefit neurofeedback, that benefit from neurofeedback training are, I skipped a slide. Sorry. Okay. Yep, it went right over it. Okay. So on this slide, we'll spend a little bit of time discussing what an actual neurofeedback session looks like for a patient. During the neurofeedback session, a patient wears an EEG cap while observing a visual and auditory stimulus, often in the form of a simple video game. While the patient is observing the stimulus, the EEG system is digitally analyzing and monitoring their brain data in real time. The video game will provide real-time feedback based on the brain data that is being gathered second by second. During the training session, the video game will stop or start depending on the level of irregularity occurring in the EEG data at any given second during the training session. We'll dive into this process in greater detail later in the slide deck. So now, clinical benefits of neurofeedback. Backed by both research and our anecdotal experience, there are some diagnoses that neurofeedback is really effective at treating that we know we're going to see a strong result on, and we really try and stay in that wheelhouse. So what we typically use neurofeedback for are anxiety, inattention, PTSD, individuals with hypervigilance, and then depression, concussion, and insomnia. Anxiety and inattention are the diagnoses where there is the most research and we've seen the strongest response from our patients. And we've seen strong responses for individuals with PTSD, depression, concussion, and insomnia, but not necessarily as strong as we see with anxiety or inattention. Neurofeedback is an intervention that's strongly backed by leading trauma experts like Bessel van der Kolk. So it's definitely an evidence-based intervention where we see good results with our patients for a variety of diagnoses. So the clinical benefits of neurofeedback are numerous. One of the greatest benefits of neurofeedback, specifically for individuals with a substance use disorder, is the idea that by utilizing neurofeedback, we are providing with our patients with an intervention that is not a pharmacological tool. This has value in helping our patients reshape their understanding of what clinical options are available to them. This is especially true for individuals who have historically been very reliant on pharmacology for solutions. We help to kind of shift their mindset that I need a pill to fix me, and we're looking at more of an internal self-regulation process. And my personal favorite part of neurofeedback is the objective nature of the entire intervention. Therapy and treatment for co-occurring disorders can be notoriously nebulous and difficult to measure. QEEG and neurofeedback provide an objective measurement for the process. We are finally measuring the target organ involved in mental health. Being able to show patients the change in their brain activity is an incredibly valuable tool for the clinical process, both as a marker for improvement and as an indicator for regression. So very often during neurofeedback sessions, I will pull up a patient's brain map, we'll see improvement, they'll verify that it matches what they've been doing, they've been engaged in therapy, they've been going to yoga, they've been taking care of themselves, they've been engaged in 12-step and all the other interventions that we offer here. And then the flip side will also be true. I will pull up a patient's brain map and it will be more dysregulated than we saw the week before. And they'll report that they've been struggling with the idea of staying sober. They're feeling really depressed. They're feeling really anxious. And it becomes another tool for us, another intervention, a way to talk to the patient and connect them to their own experience, and another data point for us to use throughout the clinical process. So neurofeedback is an intervention entirely focused on self-regulation. We work with clients to help them identify what internal tools they can rely on to assist in regulating their own nervous systems. It is also completely non-addictive. Neurofeedback is a unique intervention. Patients generally consider it fun. They get to see a side of themselves that isn't always available to them. It can be very opaque. And we show them their brain activity on a weekly basis. So it's kind of fun and enjoyable. It is an evidence-based practice, as I mentioned earlier. We are constantly assessing for change, a process that, as I said, we share with the patient in session regularly. We show them what's improving, we show them what's not, and we talk to them about it. So we use the QEEG as a clinical tool all of the time. So neurofeedback is often difficult to understand if you haven't seen it or experienced it. So we put these slides together as a little bit of a virtual introduction to what a neurofeedback session might look like for a patient. So on the left side of the screen, you see the three major players in any neurofeedback session: the computer, the brain, and the TV screen where the visual and audio cue will play. There is constant interaction between these three entities throughout the neurofeedback process. On the right side, we can see the interface between the objective data of the game, which is tied to the EEG data, and the patient's subjective experience. This is the piece of the process where having a good neurofeedback technician or clinician is so important, because we want someone guiding the patient to question their own internal experience during this process. We want the technician or clinician to be able to say, what's occurring for you when the game is playing? What's going on when the game stops? What are you thinking about? How does your body feel? Are your shoulders tense? What's your breathing like? Are you present? Do you find yourself drifting off? And how does that relate to what's going on the screen? It's in this comparison of the objective and subjective data that we help the patient increase their own mind-body connection and ability to self-regulate. While there is an ongoing interaction between the patient's conscious mind and the computer, there's also an ongoing interaction between the patient's EEG data and the video game, where the brain is being rewarded for strengthening specific pathways. It's through this mechanism that we begin to see the actual EEG data and therefore brain activity change over time. Arguably, the most important piece of the QEEG and neurofeedback process is our ability to determine atypical activity from typical activity. We use a normative database to help us make these distinctions. The bulk of our analysis includes examining where data falls across the normal distribution. Our standard for clinically significant activity would be any brain activity that has a Z-score greater than or less than 2, as that activity would be expected to occur in about 4% of the total population. The brain maps that you'll see throughout this presentation and in our case studies are all color-coded according to their Z-scores, with red activity indicating statistically significant high activity and blue activity indicating statistically significant underactivity. Now, what does statistically significant hyperactivity and low activity look like in the brain? How can we conceptualize this? We can think of the brain as either a light that is shining too brightly, such as the image seen here, or as a light not shining brightly enough, a bulb that's not exerting enough electricity to help meet the need, such as the image shown down here. So when we're looking at the brain maps, where we see the red activity, we can imagine that's a light shining too brightly. The brain is overexerting energy within a certain area. And underactivity is when the bulb isn't bright enough. There's a disconnect between the need for energy and the output that's being created. During the neurofeedback process, our goal would be to help regulate this activity, move it from the outer ends of the spectrum to a more regulated activity within the middle of the range. And that's what we would hope we'd see. We'd see everything come to the middle of the spectrum. We would see the red reduced to orange, yellow, green, then white, dark blue, light blue, cyan, white. And what we're looking at here is a perfectly statistically ideal brain, which if we all had that world would be quite boring. So a little color is not so bad. So as often experienced during the treatment process, we do not see patients get better in a straight line. This is the same for the neurofeedback process. We should not expect that all of the statistically significant atypical activity would be eliminated immediately or in a completely linear fashion. This is a process-based intervention, and what we see is incremental changes over time. So particularly in response to stressors that a patient experiences in treatment, we're going to see the brain and the EEG respond to that process. But what happens over time, as you saw this little figure bouncing up and down the screen, we're going to see some days that the EEG is activated, next day will be more regulated, but over time, we'll see those peaks and valleys get smaller and smaller until finally the patient is in a more homeostatic place. So what we have here is a 3 time points from a patient's treatment episode. The patient's protocol was focused on frontal lobe slowing, which is a pretty typical pattern that we see in our patients. It's commonly associated with attention deficits, but with that pattern, we would also see impulsivity, emotional dysregulation, and you can see it marked by this red pattern right here. The red and the orange indicates that there's too much, the brain is producing too much theta activity and slightly too much alpha activity. So as we go through this process, we told the computer to monitor these areas of the brain while the patient is playing the video game. The video game is dependent upon the patient strengthening these areas of the brain, reducing the slow activity in there. And over time, after about 5 sessions, what you see here is the midpoint, the middle session. We can see that the red, the statistically significant activity, has significantly reduced. We're still picking up some statistically significant activity, but the actual surface area, the red spot, has reduced. And then finally, by session 10, we're seeing a statistically normal brain, and that's accompanied by an internal sense of the patient being more internally regulated, less impulsive. As mentioned previously, we are constantly gathering subjective measures throughout the neurofeedback process. Like I said, it's great that we can see the brain change over time, but we always want to bring it back to reality, bring it back to the tangible experience for the patient. So we ask them questions and regularly give them surveys regarding depression, anxiety, stress, body awareness, insomnia, inattention. All of these different measures, concepts, we try and measure pretty regularly for the patients. So we get to show them multi-points of their process during treatment. So what we have here is 2 surveys that are our most commonly given surveys to the patients. The first is the DAS-21, Depression, Anxiety, and Stress Scale. Patient initially reported clinically significant levels of depression, anxiety, and stress on this measure. BM stands for brain map, which is the first time point that we would give this measure at. By session 1, we see a slight reduction in those measures in depression, anxiety, and stress. And as we move over time, we see a continued downward trajectory, which is mirrored, which reflects a improved experience for the patient. They're reporting less depression, less anxiety, and less stress over time. And by the end, these numbers are, I think the clinical cutoff scale for the stress score on the DAS-21 is a 7, and this is about at a 2, so very well within normal ranges, totally fine. And then the STI, the State Trait Anxiety Inventory. This is personally one of my favorite measures to give to patients, just because of the way that we implement it. We give this survey to patients before and after a neurofeedback session. So for us, it's a quick measure of how effective the neurofeedback session is in reducing their anxiety. So we'll give the patient this measurement. They'll complete a neurofeedback session, a 15-minute training session, and then we'll give them this measure again. And as you can see here, this patient, when they came into the office for a session, reported an anxiety level at 8.30, and their post measurement was at a 2.17. So that's about a 79% reduction in anxiety after a single session. That is a very high turnaround for that survey. I would say typically our average patients are about a 30% reduction after a single neurofeedback session, which is still significant and still strong. And that is the information that I have for you today regarding what the neurofeedback process looks like at Karen. And with that, I'm going to pass it back over to Dr. Krantz to go over some of the case studies.
Hi. So we're going to share with the case studies. So that's why we have our masks on. Hopefully you can hear us well. And we'll go ahead and start. So again, these case studies will demonstrate our whole team's input in treating these patients. Can you see Allison? Okay. All right. So this was a lovely lady, a 54-year-old Caucasian female, unemployed at the time, divorced. This was her first treatment episode, and it was an intervention by her family. Her chief complaint coming in was depression and anxiety, and the fact that she only drank alcohol a little bit more since the loss of her father about a year ago. And she really decompensated more after the loss of her father. She was very close to her father. And you'll see on the next slide, because developmentally, there was significant emotional and physical abuse by the mother. So this would be one adverse childhood event. And her medical history, the hypothyroidism, was stable at the time of admission. But she presented childlike. And my first impression was, even at 54 years of age, that, the group is going to eat her up, because her responses, her concentration, her responses were minimal. They were like probably a 6-year-old at the time. She had a horrendous traumatic brain injury in 1980. Essentially, she was in a different country. She was a professional rider, horseback rider, and was in competitions at times. It did not happen in a competition, but bottom line is her horse threw her and then rolled over her, including her brain, and crushed her brain and skull. She was in, I'll say, a third world country where the medical abilities were diminished. They actually had trouble with the craniotomy, even putting her skull back on. And she really had to learn to walk and talk and everything else. So it was a significant traumatic brain injury. She really had no previous psychiatric history as far as anxiety and depression. She was graduating college at that time, actually was able to go back after this injury, several years after, with some occupational therapy and physical therapy here in the States. She was able to go back to college and actually get a bachelor's in international business. So this woman had initially a very high IQ. She didn't test very well with us, only because of the traumatic brain injury and the residual effects, plus the alcohol use. I will say one thing about her substance history is that her first alcohol use was at age 12. And that again shows the adverse childhood events and the incidence of early alcohol use. Her RBANs, so RBANs again is cognitive testing. We have a neuropsychologist here. We're lucky to have a great team, actually. We have a neuropsychologist here, and you can see immediate language and delayed memory was seriously low. I mean, her total score was borderline. Now, this is a college-educated female, but she was the alcohol, her increased use of alcohol just pushed her over the wall, so to speak. I mean, she really decompensated a lot, but again, she had a serious brain injury, but was functioning better until her alcohol use increased. So memory, mood and memory, temporal lobe areas, her language, if you look at semantic fluency, the ability to be able to pull information out of her storage area was borderline. And that's, again, why her presentation agreed with this cognitive testing completely.
So here we have her surface map, her brain map. This would be kind of the initial baseline analysis that we do using the quantitative EEG. And we are looking to see how much of each type of frequency the brain is producing and how that compares to other individuals of that person's age. So delta is the slowest frequency that we measure in the EEG, and high beta is the fastest. Then the rest of them follow along that spectrum. As I stated earlier, the red activity is statistically significant hyperactivity. So here we're seeing a lot of excess slowing in the patient's brain, really matches her RBANS testing. We're seeing it all temporally. It's important to note, though, that because of the skull abnormalities that Dr. Krantz mentioned, a piece of this pattern can be attributed to that atypical skull.
The deformity of the skull.
Yeah.
Because
Because
it was horrible.
we were, as we're comparing to a normative database, any difference physically will affect the statistical output. So that will come back later, but essentially the majority of this pattern really is related to that, the cognitive difficulties this patient was experiencing, the traumatic brain injury, and it really fit both our clinical presentation. These frequencies would tell us if someone's producing too much delta, too much theta, too much alpha, they are going to have trouble organizing their thoughts. They're going to have trouble focusing. They're going to be disengaged. They're going to have trouble with semantic processing, all of those things that she had issues with on the RBANS. So this is where we started.
So we did, I ordered a SPECT scan at the time of perfusion study. Again, we talked about that. Sometimes MRI and CT will not show the deficits that you normally would pick up with the perfusion. And this again shows the, so these are the standard deviations. So green and dark blue and light blue are not good things. That's a deficit. So if you look here in the left temporal area, that coincided with her RBANS too, that there's a definite perfusion deficit here. And if you're looking, again, this is the left side, this is all left temporal lobe, so significant perfusion deficits. So we got together as a team, and during this whole process, not only is the patient undergoing neurofeedback, but is based on the SPECT scan and the perfusion deficits that we saw, -4, that's a significant standard deviation away. We decided to do hyperbaric on her, and she had 20 hyperbaric treatments. So the patient had 20 hyperbaric treatments, had 20 neurofeedback treatments, ongoing cognitive behavioral therapy, DBT, and EMDR, and everything our fine therapists do in between that. So afterwards, this is her RBANS testing. which correlates, which, you know, it's exciting to be able to treat these patients, because I mean, you see them day one and then you see them walk out of here. This was, as far as I'm concerned, we should probably, you know, put this in an article. 215, again, in 2016, you see the difference. Low average, borderline total. Now, even on presentation, the patient was able to speak, was able to integrate, was able to, had better memory, was able to interact much more appropriately. And that's evidenced by, these are objective data. So it's not just us saying subjectively, oh, she's better. This is objective data showing that. So you'll see the difference. I mean, she went from borderline, intermediate memory to average, essentially, or low, or borderline and low average to average. Her semantic fluency stayed a little bit, pretty much the same, but slightly better as far as percentiles. And her delayed memory was significantly improved, especially figure. So overall, she caught, from an objective point of view, was also doing better.
And here we have her final brain map. So this is actually a pretty interesting case. As I mentioned previously, some of the red that we're picking up at the post brain map is a result of the skull differences as we compare to the normative database. So there's a piece of this that we never would have expected to change. But you can see overall, the surface area, specifically of the theta activity, has greatly reduced. We're seeing way more regulation, way more green and yellow. One of the things that I think is super interesting about this brain pattern is initially we were seeing all excess slow activity. By the final brain map, we had increased beta activity too. You can see that this pattern isn't as strong. This pattern is stronger at the end than it was in the beginning. What we're seeing there is the brain workaround. The brain is compensating as the brain continues to heal and we continue to guide the brain recognized that if we were producing too much slow activity, we could activate the same area by producing too much fast and help recover some of the function that was lost in this area. So that even though it's registering as statistically significant, it is statistically significant, but it's not harmful to the patient. So these are all like important distinctions that we want to keep in mind when we're looking at brain map data.
And again, Allie was able to increase her connections in the brain, and that neuroplasticity is, again, very real. So this is the SPECT scan perfusion study, and I don't know how well you can see this, but and I have hard data as far as deviations away, you know, and we didn't put that on the screen, but just looking at it, this was the initial. Okay, so a lot of dark blue, a lot of blue, a marked decrease in perfusion in the temporal lobe. This is left temporal. And then you see in the secondary with the 20 hyperbaric treatments, actually this patient got so much better that she went on and did another 40 hyperbaric treatment on her own. And I've seen her post-treatment. And it's just awesome. It absolutely makes you want to stay in the field. You'll see here, again, the perfusion deficits were markedly decreased. Want to go to the second one? So,
Dr. Krantz, you take it.
Okay. So this was a 65-year-old Caucasian married female attorney, had been in treatment multiple times, an intervention again by the family. And the chief complaint was increasing alcohol intake the past 10 years, then depression the past 6 months, and now noticing some memory issues. So the medications that the patient came in with, an antidepressant, Lexa, amlodipine is a blood pressure medicine, atenolol is a blood pressure medicine, aspirin for prevention, and gabapentin for anxiety. Significant medical history, lumbar laminectomy, hypertension. So again, brain trauma. So we try to pick patients that had brain trauma or adverse childhood events. Both of these had both, actually. And he had a right, or she had a right CVA with left hemiparesis. So left side was paralyzed, but with therapy, there was no medical sequela with any kind of left hemiparesis when the patient presented it to us. Fatty infiltration, again, progression of the disease of the alcohol use disorder. Depression and anxiety was getting worse. There was a family history of mental health disorders as well as the alcohol use disorder. A traumatic event for the patient that she never dealt with was, again, she was 12 years old when her father died. This was a very educated, I can't say that I graduated from Yale and Cambridge, female, and the memory loss you'll see on the data that we'll show you further shows the cognitive decline. A physical examination was essentially negative, substance abuse history, first use age 4, again, an adverse childhood event, problem that they identified for the past 10 years, and drinking about 16 ounces of vodka a day. Abnormal labs are pretty typical, with a biomarker for diabetes being elevated, the hypertriglyceridemia that occurs with alcohol use, and the macrocytosis, as well as the low magnesium and the elevated liver enzymes. A lot of that did normalize, but not completely, not with the diabetes. This is the cognitive test, the R-bands. Okay, so you have a highly educated person that is well above, probably high IQ, that in testing, again, immediate memory and delayed memory. So frontal temporal areas of the brain obviously are impacted. This should be superior all the way across the board. If an educated pre-morbid guess would be of mine.
So here we have his brain map, and you can see it's quite a different image than the initial map that we were looking at, with all the excess power across the slower frequencies. What we're seeing here is deficient delta theta activity, deficient and excess beta activity. This is a pretty common brain map that we see specifically for individuals with alcohol use disorder. The deficient delta theta tells us that an individual is not resting, the brain is hyperactive, the brain is not relaxing the way that it should. As you can see, kind of all of these, the top level circles are all towards the green, blue, underactive side of the spectrum. This is something that we see very often with advanced alcohol use disorder. We start to see actual dehydration of the brain, and so that's where we see the low power come in. This deficient delta theta is accompanied by excess beta activity, which is too much fast activity in the brain. So not only is the brain not effectively slowing down, not effectively resting, it's also overfiring and producing too much energy. So we'll see anxiety, we'll see restlessness, we'll see insomnia. So pretty typical pattern to start with for this patient.
So what we did again, so we ordered the SPECT scan, the perfusion study, obviously worrying about frontal temporal dementia in a 65-year-old, the progression of the alcohol use disorder. That's usually the dementia that we see. And on here, you'll see the post CVA on the right side. And you'll see even areas on the left side that are markedly decreased in perfusion. The right temporal, significant decrease in blood flow, left temporal, less so. So again, we get together as a team, we discuss the case, and this patient also went to hyperbaric, received 20 treatments of hyperbaric, did the neurofeedback,
20 sessions.
20 sessions of neurofeedback. And again, it would be great if we could delineate like what was doing the most, but that would not be fair to the patient. We want to treat the whole patient. So, but that would be good research studies. So they had the dialectical behavior, CBT, EMDR in this case also.
So this is a beautiful example of the patient's data. After about 6 weeks of neurofeedback sessions, but then not 6 weeks, we did 20 neurofeedback sessions. And you can see this is a typical process that we would expect to see during neurofeedback. The statistically significant dark blue activity has resolved. We're now seeing that it's within the normal range. This hyperactivity that we were picking up in beta has now resolved. It's in the normal range. What I like about this data is that you can see the same general pattern time and time again. You can see that this map belongs to this patient. The patterns are consistent. What we're seeing change is the magnitude, the severity of the pattern. And this is a much more homeostatic, much more regulated brain map than the patient presented with.
So this, we did pre and post SPECT scans, and you can again see the difference. So again, the dark blue, the light blue, the green is also 2, 3, 4 standard deviations, a decrease in perfusion. So this is the baseline. This is where she was upon discharge, and you'll see the change. So there was increased perfusion in the frontal lobes. There was, and in the temporal lobes. I mean, probably this is the one, right and left temporal here, you'll see, I mean, this is markedly increased perfusion, more green than dark blue. And on the left side, you'll see it also. This patient, again, did much better. And the progression for this patient and the differential diagnosis would have included alcohol dementia. She has not presented with that. Was able to even, there was some increased limbic activation on the SPECT. I don't have all the SPECT slides here, so you can't see that, but the connection to the limbic system and prefrontal cortex on his slides actually showed the ability for emotional release and being able to express his emotions at the time of discharge. You want to talk about that?
Sure. So this is just an interesting slide that we put together. This would be a great avenue for additional research, but it's just looking at the correlation between the results that we got on the QEEG and the SPECT scores. I have highlighted here what the minimum scores were on both measurements. So you can see there's a pretty strong correlation between what we're picking up in the QEEG and what the SPECT scan was able to pick up across all of the Broden areas. Which is a term that we haven't used yet,
Right.
which we regularly use in neurofeedback. It is subdivisions of the brain based on neurons dividing the brain by structure and function. So just a nice little overlap of the measurements that we use.
So that's the end of our case presentations. We just put in a couple of other slides, again, to remind you that and I'm sure all of you in the profession know this, but to remind our patients that if our thinking is in that stress mode and there's a lot of anxiety, fear, self-hatred, self-condemnation, self-rejection, anger, rage, bitterness, unforgiveness, jealousy, rumination, that excessive thinking, that will directly affect brain function and behavior and perceptions. And those all could be changed. And whatever the etiology of that is, needs to be treated. If we look at growth thoughts, or you want to say maybe homeostatic thoughts, gratitude, peace, love, joy, compassion, collaboration, harmony will give you a feeling of well-being and produce neurochemicals that support that. It really is a biological model of change. Do you want to talk about this, Ellie? Okay. Me?
Yeah,
Okay.
you go.
Okay. Okay. So bottom line is, the familiar past, unlearning, breaking the habit of being yourself. Again, your brain is who you are. Primary synaptic connections, unfiring and unwiring, and that's all in Allie's bailiwick. Identifying the emotion in the body, losing your mindset, really changing your mindset to a healthy mindset, becoming familiar with the old self, deprogramming, living in the past, old energy. And now the hope is that we're in our abilities, and this is what's exciting. I mean, this is, where the rubber meets the road with our patients. So relearning, reinvention, a new self, yes, because of our own old mindset that we're able to change and therefore sprout new connections in the brain and form new memories. Becoming familiar with who we are, that reprogramming, and obviously creating a new future. And the fatigue and depression and anxiety and everything else that we see, we're able to treat, and the new energy that happens is very real. So we have, again, being an old doc, we have a lot that we can do with our patients today, a lot of modalities, and everyone doesn't fit the same modality. We don't do hyperbaric and this and that and neuroimaging. And actually I use more FDG PETs now than the SPECT scan because it's easier to delineate different kinds of dementias. We've had Lewy body dementia, we have alcohol dementia, we've had Alzheimer's, and it's easier on the FDG PETs to actually look at that and with the perfusions. So there's a lot that we can offer our patients. This is not a static field, to say the least. We are able to and help them understand, because a lot of these are in color, in black and white, and they can see, not just their lab work, the simple stuff, but they can see all of this and their progression. Especially when Allie is in there and cheering them on, and she actually shows them their brain maps from could actually see it on their brain map. So they are starting to understand the connection. So this is a great field to be in. And I know we'll have more information and new knowledge and be able to really do great work with our patients. Those are references. We have to put those. Okay.
Fantastic, ladies. This was amazing to hear. I took some notes. I see everyone in the chat box appreciative as well. This is incredible. I am willing to bet that we can even do a part 2 of this. If the attendees and audience would like, I'm sure our community could certainly benefit. So we'll have to look at that in the future. Something that stands out to me, one of my biggest takeaways from this, Dr. Krantz and Allison, is that you have continued to share the fact that this treatment modality provides so much hope. And that aligns so perfectly with the mission of Karen, in that we're hoping to restore hope for the individuals and the families that we work with. So this is amazing. So we're at about 1:23 and we will end at 1:30. We'll do some Q&A, and I'm going to go in the process that the questions were received. We're not going to get to all of them, but don't panic, everybody in the audience. We will get back to you individually with the answers to your questions. So the first question, Dr. Krantz or Allison, why and how is the 12-step spiritual program of action to be applied in this context?
You want to take it?
Okay. So being in recovery, if you look at it, if you look at everything that we spoke about today, okay, changing your thinking, and you look at the 12 steps of AA or any kind of spiritual program or the Bible, or talking about how we think, what we should think on, how we should be accountable, how we should forgive, how we should not hold resentment, how all of that people going through the 12 steps of AA will learn, and amends and things like that. What they're really talking about, again, is memory, changing memory, letting go of the past, and reforming new memory and new real estate in the brain. And that's neuroplasticity. And we have the ability to do that. So it coincides with, again, if I think it was Confucius that said, if you hold on to something, you're only hurting yourself. And that's the bottom line. So, a spiritual program, I believe where body, soul, and spirit really enhances recovery.
That's right. Wonderful. Our next question, how do you use the information provided today within sessions for clients?
I would say in a variety of ways, however it's appropriate. So we do, for all of our patients at Ocean Drive, we do an initial integrated assessment. So that includes the R-bands, the MCMI, the brain mapping, and a blood screen. And for that, we present kind of this initial evaluation of the patient with all these different data points for them. And we use it in a way where they feel validated and seen, and we help reflect back their own experience to them through the use of data. It is then used to guide treatment planning, to pull in additional interventions. This information is used to measure progress, to show change. Anything else?
No, I think that's perfect. I mean, that's essentially what we do. The patient is always informed and involved in the process. And we tell them why we recommend this or that, or do they need more psych testing or projectives or whatever, may come of it. But the patient's informed, and many times we meet with treatment team, with all the clinicians. So we just have a think tank, I think.
That's right. That's a good point. And I'll highlight that for our audience and professionals. If you have not worked with us at Karen before, and perhaps you have a patient of yours, an individual who you think may, be an excellent fit for neurofeedback, for working with Karen, I want you to know that Dr. Krantz and Allison are actively involved in all of the cases. They are working directly with the primary treatment team, with the entire medical team. They're in case consults. They are part of the treatment planning process. They speak directly with you, providing this information, permitting we have an ROI from the patient. They are speaking directly to the patient and the family. So they are not strangers to the treatment process at Karen. Who you're seeing today is actively involved in supporting your patient. So that's a great point. I think we're about out of time, but I'm going to ask one more for just kind of a quick follow-up question. What is the recommended time for participation in aftercare treatment in relation to neurofeedback?
That's a great question. It really is individualized and data-driven. The good thing about neurofeedback is because we're training to a norm, there will come a point where the brain reaches the norm. It is a measured and measurable goal. Once we see that the brain has reached that norm repeatedly, that pattern has stabilized, the need for neurofeedback no longer exists.
Right.
We are very much trying to work ourselves out of a job with neurofeedback. But it is different for everybody. Like I mentioned earlier, there's some diagnoses and some brain patterns that are extremely amenable to neurofeedback. We can see good, solid, very steady change within sessions 5 to 7. And that would really be those anxiety patients. Other diagnoses, other brain patterns are going to take longer, and you're going to need 20 sessions, 30 sessions. But it depends on the brain. I can't give like a firmer answer than that.
That's
And
right.
one thing that Allie did not have time to actually mention is we also use alpha-stim for anxiety, depression, and insomnia. And most of the patients come in with insomnia as part of withdrawal. So whether they're a candidate or not, that will also show on the initial brain mapping.
That's right. Yeah, we are definitely going to have to do a part 2. So thank you, ladies, so much for this. I appreciate it. Everybody appreciates it. So as a reminder to all of our attendees, this presentation is eligible for 1.5, so 1.5 continuing education credits. Watch your email immediately after this, as soon as we close it, for a link from ce-go.com to complete your eval. Before we officially close the session, I just want to share we have a really exciting upcoming webinar, again, available from Karen on later this month, Wednesday, January 26th. It will be on opiate use disorder with one of our therapists from our campus up in Pennsylvania, Christopher O'Shanney. The webinar will be from 12 to 1 and offer 1 CE credit through the APA. We hope to see you there. So in the meantime, if you have any questions, feel free to reach out to myself or your local regional resource director. I know they're on the screen here, and I'm sure you have a relationship with your local RRD as well, but we're happy to answer questions about this presentation, about Karen in general, and be a support and resource for you in the community. Thank you so much for all of your time. We're grateful that you were here today, and I wish you a beautiful rest of the year and a healthy next few weeks ahead. Take care. Bye.
Thank you. Thank you.